of all, I'd like to thank everybody for hopping online today, this afternoon. So my name is Marcus McCray. I'm the clinical sales specialist for Abbott and MitraClip. You guys are going to be doing your first MitraClip case. I know the whole team is very excited. Next Friday, the 17th, that morning. The implanters involved are Dr. Chirag Bavishi, Dr. Raj Karuparthy, Dr. Senthil Kumar will be doing echo, and then also Dr. Mayabel Cohen will be the surgeon involved with this procedure. So I'll just start here. Just a quick agenda. One thing, guys, if you have any questions, absolutely feel free to stop me. Ask then and there in the moment. I don't like lecturing too much. So we can keep this an open dialogue if you have anything beforehand while I'm talking through it. So as you can see here, just on our agenda, really what I'm doing, if you kind of look past this, is I just want to tell the story of what is MitraClip and mitral regurgitation? Why are we doing MitraClip? The type of patients that we'll be treating, and then just a few things, to understand about the procedure. I'll have a video for you guys if it plays. Sometimes it doesn't online, but hopefully it does. And then we can talk about some post-procedural care, what to expect, and then a few things on clinical benefits. Correct me if I'm wrong, you guys are already doing, you have been doing TAVR for a while, and you're also doing Watchman, is that correct?
Yes.
Okay, perfect. Well, that's good to know, because these patients, after they receive the MitraClip, it's work as far as the type of patients that you'll be taking care of post-procedure. We're very similar to TAVR and Watchman. So we're really not, changing anything too much with MitraClip. So we'll start with the mitral valve anatomy. One of the reasons why I like showing this is just all of the complex structures and what can happen to the mitral valve, especially when you have mitral insufficiency. And so as you can see here, you have your two mitral valve leaflets. Those are actually what we're going to bring together percutaneously, and I'll explain that in a moment. You have your chordae tendineae, which we obviously try and avoid, papillary muscles, but anytime you have an issue like a chordal rupture or a displaced papillary muscle, or even in my experience, I've seen a ruptured papillary muscle. All of those things can be treated with MitraClip. When you look to the right, this is the surgeon's view, as I like to call it. Imagine you're the surgeon in the left atrium looking down on the mitral valve. This is just an idea. If you ever look in the notes or you see something like MitraClip placed at A2P2, you have a good idea of where exactly that device is placed, and it's down in the middle. 90% of the time we're going down to A2P2, but every now and then, if you do have a jet out in the medial commissure, which is at A3P3 or A1P1, which will be lateral, we can also treat those with MitraClip as well. So MR, there's two types of mitral regurgitation. You have your primary mitral regurgitation, or also called degenerative MR. And if you look down on those four boxes, that would be your prolapse or flail. So what I talked about earlier, when you have a chordal rupture, anything of that sort, whether it's your primary, secondary chordal rupture, when you have a prolapse, it kind of causes this parachute effect. You'll have a very eccentric jet of blood going back into the left atrium from the left ventricle. Obviously, that's not what we want. The same thing for a flail. Oftentimes, you'll see that leaflet flailing up into to the left atrium. Lots of MR, very eccentric, and by eccentric, I mean wrapping around the whole left atrium. And then you have secondary MR, also called functional MR, and that results from LV dysfunction and dilatation. You can also have annular dilatation, due to atrial enlargement for these patients who a long-term AFib and their left atrium has enlarged that way. And really with your functional MR, there's not necessarily an issue with the cord in a sense of like a chordal rupture. I think that's why they call it functional, but that's just when those leaflets are unable to touch or coapt due to that annular dilatation. All right. Any questions on MR? Perfect. So why are we doing MitraClip, right? So quickly, I'll just kind of take you through, just a few statistics on mitral regurgitation and why there's an unmet need for repairing your insufficient mitral valve. So if you look down at prevalence of valvular heart disease by age, obviously you guys are doing TAVR, so you can see that aortic valve disease line towards the bottom. But then the yellow line is the mitral valve disease. So mitral regurgitation is more common than your aortic valve disease. And then obviously, as you would imagine, the older these patients get, the higher probability or prevalence they have in having aortic valve disease, mitral valve disease, or all valvular disease. With your aortic patients, especially aortic stenosis, these patients are symptomatic. They need to be treated relatively quickly. It's something that you notice right away. MR can sometimes be called the silent killer. Because, as you can see here on this, 1 year mortality with severe mitral regurgitation can be up to 57%. And so oftentimes these, especially when you're talking about heart failure patients with secondary or functional MR, they may start off at, moderate MR. And then as that disease progresses, it continues to moderate to severe and severe. And so that just increases load and stress on the valve and left ventricle, muscle damage and loss of that LV, dysfunction of that left ventricle. If you've ever seen an ejection fraction, down in the 20s, 15, 10%, dilatation of that left ventricle. And then obviously with the dilatation of the LV, bringing that or pulling the valve further apart, you're going to have more mitral regurgitation. So it's just it initiates a cascade of events progressing to heart failure and then death if not treated. Just here, as you would imagine, the worse your MR is, the lower your survival probability is. So when we talk about MR, mitral regurgitation, just remember it's on a scale of 1 to 4. 4 being the worst, that's your severe. 1 or 0 would be mild or no mitral regurgitation. And so obviously at the end of all of our cases, that's what our goal is. I'll kind of speed through this a little bit here, but what it's showing is it's just showing that, this is 2012 data, but in 2012, they had 4.1 million patients in the US walking around with mitral regurgitation. Of those eligible for treatment, whether that's surgical or percutaneously, these patients have to be moderate to severe. So that would be, that 3 or greater range. And then the annual incidence of these patients with moderate to severe mitral regurgitation is 250,000 a year, or 14% newly diagnosed every year. And then notice at the bottom of this, kind of this pyramid is the amount of patients actually being treated surgically is very low. So, personally, I don't believe that it's still at 2%, just with the modern advances, especially when you have imaging. But even if only, 5 to 10%, 10% of patients, with moderate to severe mitral regurgitation that are eligible and need treatment, they're still vastly undertreated. So there's a large and growing unmet need. And so, for a very long time, really, you have 3 options of what you can do with these patients with mitral regurgitation. The first option is nothing, which is obviously the worst. Second would be medical therapy, which is less invasive. But then on the other end of the spectrum, you have surgery. And so, percutaneous, or as they're calling it now, transcatheter edge-to-edge mitral valve repair is something that falls in the middle. Okay. And really, we are MitraClip. The MitraClip device is the only FDA-approved transcatheter edge-to-edge device that's been on the market. And when it was first FDA approved was in 2013. So we've done over 100,000, treated over 100,000 patients. There's, 13 years of clinical experience and data on MitraClip. Over 60,000 patients have been involved in clinical trials with MitraClip. So while this may be relatively new and seem like a novel technology. There's a lot of robust data and experience with this device already in America and around the world. All right, so indications. I don't have to go too far into detail with this, but you know, we are indicated, MitraClip is indicated to treat patients with primary or secondary mitral regurgitation. So that basically means all comers, if these patients are moderate to severe mitral regurgitation and symptomatic, then we can treat them. The only difference being is for your primary or degenerative. So remember, that's your flail or prolapse. These patients need to be evaluated by a surgeon to make sure that they're at high or prohibitive risk for mitral valve surgery. If they are, then they go to the MitraClip bucket. When you have your secondary or functional MR patients, these are your heart failure patients. Those are a little bit different. They don't need to see a surgeon necessarily, depending on the team. MitraClip, the data for that is very, very strong for those patients, and the surgical literature is not. So it's favored there. Contraindications, just something to keep in mind. With MitraClip, if these patients can't tolerate procedural anticoagulation or post-procedural antiplatelet regimen, they're contraindicated. One of the things that I have mentioned to a lot of people is if these patients have a heparin allergy, because we will be given heparin throughout the procedure, that's okay. We can use Angiomax. So that is not necessarily a contraindication if you have a heparin allergy. We just want to make note of it. If the patient has active endocarditis of the mitral valve, they're contraindicated. If they have previously had endocarditis and no longer active and look like a suitable candidate, then we can treat them with the MitraClip device. Rheumatic mitral valve disease is obviously a big contraindication, and then any sort of evidence of a thrombus would be a contraindication as well. Any questions just on MR severity prevalence as I kind of roll through this? No? Perfect. All right. So pre-procedural care, kind of what is MitraClip? All right. So one of the things for you guys to consider, what do these patients look like pre and during the procedure, is the patients will be intubated. They're under general anesthesia. This is we get right femoral access, and the sheath is a 24 French sheath. So this is on a beating heart procedure. We're not arresting the heart. We can notice, hemodynamic changes or reduction in MR all in real time. And again, like I said, hopefully these videos work later on, just so you guys can actually see that. I have a few examples for you. It does say in here, patient may have a Foley catheter in place. I talked to Dr. Bavishi. That is not going to be the case for you guys. So again, it just depends on the institution. And then the patients will be heparinized during the procedure, just to prevent any sort of thrombus. One thing to keep in mind, especially post-procedure, is about 90% of the imaging that we are doing, whether it's transesophageal echocardiography or X-ray, 90% is TEE. So these patients will have a TEE probe in place for the entire duration of the procedure. All right. So here's kind of a system overview of the MitraClip itself. So if you kind of start down at the bottom left, you can see it's a two-part system. So it comprises of your steerable guide catheter, which you can obviously steer that in multi-directions. And then through that steerable guide catheter is the clip delivery system. And then all of that at the very end is your little MitraClip device right there. We have 4 sizes. So again, I talked about earlier about if it's functional MR or degenerative MR, we have clip sizes that work for those. For each unique individual valve, we can mix and match. Just so you guys are aware, the national average of clips per procedure is just under 2. So, more often than not, we're leaving more than one device behind. All right. I'll talk a little bit about the top one more, but the main important part is, again, real-time assessment of mitral regurgitation under normal loading conditions. We're not doing rapid pacing. We're not doing anything of the sort, not arresting the heart. It's, just a right femoral access, transeptal puncture, and then grabbing the leaflets where the leak occurs. One of the things, as far as when you're looking at the MitraClip device, the implant itself, it's mostly comprised of cobalt chromium. It is MRI safe post MitraClip procedure. And then the white covering is a polyester cover designed to promote tissue growth. That clip will endothelialize with the valve over time. So I'm going to go ahead and play a video here. I can see it on my screen. If you guys don't see the animation, please let me know. Or if you don't hear the audio, let me know.
The blue flow filling the left atrium illustrates
you guys hear that?
Mitral regurgitation, or MR.
Perfect.
The percutaneous mitral repair system consists of catheters and the MitraClip device. The catheter is introduced over a guide wire that has been placed using standard techniques. The dilator is used to gradually advance the guide into the left atrium.
So again, transeptal puncture, and then we exchange for our steerable guide catheter, and then through that is the MitraClip delivery system.
Into the left atrium. The clip is precisely positioned above the leak in the valve.
Again, a lot of the times, these patients that we see, maybe they've had a previous open heart or rotated anatomy. We can steer our device in any direction that we need to for each individual unique heart.
Color ultrasound imaging identifies the severe MR illustrated here with blue flow. The clip is advanced into the left ventricle below the valve leaflets. The clip is retracted and closed to hold the leaflets together to reduce MR. If the MR reduction can be further improved, the leaflets are released and the clip re-advanced. Positioning adjustments may be made and the leaflets are grasped again to reduce MR. The double orifice opening allows blood to flow on both sides of the clip. The grasp and MR reduction are assessed before the clip is deployed. The catheters are then removed. Securely attached to both leaflets, the clip moves with the valve, allowing blood to flow through each opening. The mitral valve is repaired without open heart surgery. The MitraClip device is made of metal and covered with a polyester fabric to promote healing.
All right, perfect. So hopefully that video kind of helped bring everything together so far that I've talked about, what it is we're exactly doing for the MitraClip procedure. One thing to keep in mind, again, the example that showed a majority of the time we're at A2P2 where there's fewer cords. All that we're doing here with this MitraClip device, almost imagine it kind of like a clothespin, is we're just grabbing both of the leaflets exactly where that leak is or the malcoaptation is. And then because we're not, bringing any cords with us or anything of the sort, the heart will just continue to function as it's normally intended to. So when you can kind of see on that bottom left picture, once we bring the leaflets together and deploy the device, we leave kind of a double orifice opening where blood continues to go through either side of the device. Just as a reminder, again, this is no need for cardiopulmonary bypass. This is a beating heart procedure under normal loading conditions. We just have that TEE probe, placed for imaging. What's very important, and the animation showed this, is you can reposition the device. Okay, so it's not like we have one shot on goal. Because we can see everything in real time, when we're going on our color compare for TEE and closing the device, if we're not happy with the MR reduction, we can simply reposition the device. We can bring it back into the left atrium. We're making sure, obviously, to never cause or create mitral stenosis. So I have had questions, what if you can't leave a clip behind? Well, we can safely bring it back into the left atrium, close it all the way, and take it out with no harm, no foul done to the valve itself. So it is an incredibly safe procedure. In our most recent study, when we looked at treating MitraClip with heart failure, patients suffering from heart failure and secondary MR, the freedom from complication rate was 97%. So MR is assessed in real time, like I said, under normal loading conditions. So that allows us to reposition and get the optimal desired outcome, again, with 4 clip sizes to choose from, depending on the valve etiology. Any questions on the animation or procedure? Hopefully I'm not going too quickly.
Hey, Marcus.
Yeah.
Hey, I got a question. So I think I missed it. Are you going through the septum?
Yes, correct. Yep. So we're, go ahead.
Is a risk of shunt, is there a risk for a shunt at all? Or is it, since it's atrial, it's not a big deal?
Yeah, no, that's a great question. The short answer is because it is atrial, it's not as much of a deal. One of the things that we do, because it is a 22 French sheath going across that septum, that's the size of our steerable guide at the distal end where it'll be across the septum. When we take all of that out at the end of the case, that's one of the last things that we do is we'll evaluate to see if there's a shunt, especially if there's a right to left. I've done over 700 of these procedures. If my memory serves me right. I have only been a part of 4 of them to where we went in and put in an ASD plug because the physicians were concerned. So over time, that septum will begin to heal and start to close up to where the hole's not as large.
Okay, good. So you would know that if there was one, you would know it before he leaves the case. I'm just making sure my nurses.
Yep, absolutely.
Okay.
That would be something that would be documented. And again, I've also had a few instances where we're like, we see a bidirectional shunt, or it is going, a little right to left, and so they'll just make note of that and look for that on surface echo, or if they do need to get a TE, later. But again, more often than not, that's not something we have to worry about.
Okay, great. My last question is that before it leaves my mind, is that you said it's got a coating to promote growth on it. Is this something that they're going to take anticoagulants for a certain period of time, or are they doing it for the rest of their life?
Mm-hmm. Yeah, no, that's a good question. And I will on my next slide cover that because they will take anticoagulation for a certain period of time, especially if they have to have another procedure. So great question. I will get to that in just a second, just on the post-procedural information. All right. So if any other questions, those are really great questions. Guys, please stop me and ask them. More than happy to answer them. On this here, the key design features, I just want to reiterate the MitraClip is MRI safe. If there is a patient that needs an MRI, MU would like to get some more information, just please reach out to myself, email, text, or call me, and I can send you a little bit more detailed information just on, the type of settings that they will need when they MRI the patient. But it is MRI safe. Here's some imaging just to show you guys kind of what it is we're looking at. So Again, these 4 boxes on the left, that's TEE. That's primarily driving the imaging of the procedure itself. We use 2D as well as 3D TEE for steering, orientation, grasping, all of the above. As you can see, we use color compare as well. That's very helpful. And so again, 90% of the time, we're just looking at TEE. And then if you look over to the right for fluoro, we use fluoro for markers on the device, as well as once we deploy the device, just to compare that with the TE on clip stability. But we're basically looking back and forth between these two the entire case. I talked about in real time, noticing the MR reduction in real time. If this plays, which it looks good on my end, you can see the mitral regurgitation on the left screen, all of that flow, that color coming back into the left atrium. The device is still, I'll play it one more time. The device is still in the left atrium, so they're just positioning. And then if you look over on the right screen, same view, the device is on, they've grabbed the leaflets and now they're slowly closing. And again, if you guys can see this like I can, you can see this dramatic reduction in mitral regurgitation, in real time. That's what we want to see in the procedure. If we don't see something like this, we know maybe we didn't get a good grab, maybe the device is rotated, and we can go ahead and fix that. So again, I guess I was going to have it close off. I'll give it a few more seconds, but you can see the dramatic reduction in MR, and then on the left screen, that's the pre. So that's the goal of what we want to see in every case, and this is a true example of just when you're noticing the true MR reduction under normal loading conditions. All right, post-procedural care. So the patients are, they've decided patients are going to go to PACU after MitraClip case, and then they'll go to the floor with you guys after that. One of the main things to remember, sheath care, it's a 24 French sheath at the groin. I believe they're going to use per close. I know they'll also have figure of 8 available, but I believe Dr. Bavishi wants to use per close. So again, just standard post-sheath procedures, things that you guys are, comfortable with when it comes to TAVR and Watchman. Bed rest 6 hours after sheath pull. One of the things when you're comparing MitraClip to TAVR, these patients don't have to be lying fully flat like I believe TAVR patients have to. You can elevate the bed to around 30 degrees. Again, the main thing is not cardiac related. It's more so the sheath site in the groin. You just don't want to aggravate that limb. Monitoring, diagnostic testing. So these patients will receive, they'll receive a TTE before they're discharged. So around 90% of the patients that we do are going home the next day and the next morning. So they'll receive a surface echo prior to discharge. If they feel great, MR looks good, clip looks great, and all of that can be seen on surface echo, then they can go home and then they'll have a 30-day follow-up. If everything looks fine after that, then the patients don't need to be seen for a year. Labs and diet, all of that's pretty standard. And then when you're talking about medications, so ANSEF will be ordered pre-case at 6 and 12 hours. Again, keep in mind if these patients are on Coumadin before the case, they can restart it that evening or the following morning, just depends if they're up feeling all right. Aspirin regimen will be started that evening and continued for a month. If the patient is on aspirin, or on Coumadin, I'm sorry, just remember lower dose aspirin for them. Patients already on the aspirin regimen will continue their current dose. The patients will be given a loading dose, 300 of Plavix, as soon as they're awake and able to swallow pills, and then home medications ordered as appropriate. I do want to talk about complications, just things to keep in mind post-MitraClip procedure. Oops, sorry about that. One of the things really when it comes to complications, remember this is a transeptal puncture. and it's a pretty specific site where we're going so that we have enough height above the mitral valve, so where we're crossing in the intra-atrial septum. So pericardial effusion, tamponade, that's something that is a risk. And something to keep in mind. Again, we're monitoring the blood pressure, everything, when we do the transeptal. And so obviously if we notice a change in the blood pressure or something's going on, we can stop, look for an effusion. But again, same thing, if you guys notice any, specific signs and symptoms, with these patients that looks unusual, then what's probably going to happen is they'll receive a surface echo, and if necessary, more testing like a TEE. Any other complications could be bleeding hematoma from the sheath site, like I mentioned. I have to mention a partial clip dislodgement. That's if the clip is only on, let's say it comes out of one of the leaflets, is only on one leaflet. That happens less than 2% nationally, so it is incredibly rare. And 95% of the time, we notice it right then and there in the case. The remaining 5% would be within the first 30 days. So again, just something to, if the patient complains of, symptoms very similar to severe mitral regurgitation, again, surface echo is the best way to go in, check, see if there's mitral regurgitation, the movement of the clip, all of those things. All right, discharge. Let me see here, I gotta move something. There we go. Discharge, these patients are going to need to inform their healthcare provider of their clip placement because they will need antibiotics before any procedure for 6 months. So just keep that in mind. They'll receive a MitraClip implant card. I believe TAVR does that. I'm sure Watchman does as well. But we have a card during the case. We'll have the device and lot number, all of that information on there for the patient to take home, as well as some take-home information. One of the things to keep in mind, just standard post-sheath restriction for activity for 2 days. Following that removal, and then any additional 30-day restriction of exercise and activity is recommended. Again, not so much from a cardiac standpoint, but more so just from aggravating that sheath site. So if you do have an 87-year-old who just received a MitraClip, just tell them to hold off on that marathon.
I have a couple of questions that popped up on chat.
Yeah.
Nikki asked, that's okay. Nikki asked, should we call you if we have a patient in the future with a MitraClip who needs an MRI?
Yeah, go ahead and call me. And then, like I said, I can send you a much more specific letter from Abbott on MRI information for MitraClip and the type of settings that they'll need for that device.
Okay, and then Mac asked, is there an increased risk of clip failure in tachyarrhythmias or with vigorous exercise?
Great question. So that the answer is no, especially if you're talking about post-procedure. Now, during the procedure, if the patient's tachycardic, it can be kind of difficult to grab the leaflets. So sometimes we'll try and slow them down because it just makes for grabbing a lot easier. A good example that I can tell you is I was over at KU. I'm based out of Kansas City here. I was over at KU Med Center. We did a MitraClip on the patient, very successful case, and the patient was still tachycardic, so they decided to cardiovert the patient right after the case. Once they cardioverted the patient, the clip was stable, the MR looked great, just as it had before, and everything was fine. So if it can withstand that, obviously in a sort of tachycardia or exercise, once the patient, after that 30-day restriction of exercise, they're good to go.
Mac also wants to know, does the patient need to be in sinus rhythm for the procedure, or is AFib still doable?
AFib is still doable, and it's pretty common.
And then Ali, our pharmacist, asked, are patients with MitraClip plus AFib now considered valvular atrial fibrillation and therefore may no longer be on DOACs?
That is a good question. That's not something I have been asked beforehand. I think that would be a more appropriate question for Dr. Bavishi. So if you want, I can get you in touch with him, just because that's not a question that I've had come up.
That's all I have right now.
Okay, perfect. All great questions, guys. These are good. Okay. So yeah, this is kind of the wrapping up on the end of it, just clinical benefits. So this is from our COAP study that was done. They looked at over 600 patients and compared them, their outcomes with guideline-directed medical therapy alone and MitraClip with guideline-directed medical therapy. So when we're specifically talking about these, heart failure patients with functional or secondary MR, sometimes these patients, they're known as, kind of your frequent flyers. They're in the ER a lot with a heart failure hospitalization, sometimes several times in a month. When they decompensate. And so, it's very important to the hospital, especially the patient, their family, to keep them out of the hospital. One of the things that they found in this study, when again, you're comparing guideline directed medical therapy, there was a 47% reduction in heart failure hospitalization. And if you look, you can immediately tell that the two lines divert away from each other. So MitraClip is very effective in treating that. The number needed to treat to prevent one heart failure hospitalization is treating 3 patients with MitraClip. So it's very, very strong data. Second would be MR kills, and we know that, and we learned a lot from that with this COAP study. Again, when you're looking at MitraClip plus GDMT versus GDMT, they saw a 38% reduction in mortality with that MitraClip and GDMT group. So one of the things to keep in mind is, especially when you're talking about your functional or secondary MR patients, these heart failure patients, receiving a MitraClip allows physicians to help better manage these patients. More often than not, patients are able to come off of drugs. That's obviously the goal, so that's one of the things that can happen. And again, preventing heart failure hospitalizations, keeping these patients alive, as well as the quality of life. So in the end, just to summarize everything, so we are the first in-class transcatheter mitral valve repair system. It's a safe, it's a reliable reduction of MR, immediate improvement in patient symptoms, and then most importantly, keeping these patients out of the hospital alive and feeling well. So that is all that I had for my slides. Did you guys have any other questions while I exit out?
Hey, how long is the therapeutic life for this device? Is there a certain amount of time that it's good for on average?
Yeah, great question. So the device is with the patient for the rest of their life. We have 5-year data that shows a very durable reduction in MR. And, more often than not, like we've seen in COAP with our 3-year data, from our earlier trials, these patients that did well, that responded very well to the clip, are the ones that, we went in, we treated them at the right time, not too late when your ejection fraction is like 10%. And we got a really nice durable reduction because, again, MR kills, MR is bad. There's this continuous cascade effect. So more often than not, when these patients go home with, mild or less MR, they're going to do very well long term. And again, they're a lot easier to manage with their cardiologist or their primary care physician. So the durability for MitraClip is very strong. Any other questions, you guys? Let's see here. I will stop sharing here. Perfect. Okay. Let's see. Okay, so we've covered everything in the chat. Yeah, that's all I have for today. Anything else? All great questions. Hopefully that makes sense of, why we're doing it, what we're trying to accomplish, and then most importantly, what to expect from these patients after a MitraClip case.
Thank you, Marcus. We really appreciate you taking your time to come on here and give us a quick in-service on the MitraClip. We're really excited to start this therapy.
Absolutely, absolutely. Very excited. So what I can do, Corey, is I can, if you guys know you recorded this, but I can always send you my slides just in case anybody wants to take a look. And then I will be on site Thursday afternoon. I can always stop by, and if there's any sort of, patient, information that you guys may need, I can provide you with that.
Oh, that would be great. Yeah, if you can send me your slides, I'll also have those available for the staff.
Okay, perfect. Well, I'll do that as soon as we get off of this. But yeah, to wrap it up, guys. Again, if you have any questions, Corey has my email, or you can see me in person. I'll be there in town Thursday, and our first case is on Friday. More than happy to help, or if we ever need to do any other in services. So yeah, I appreciate your time. Thank you very much, and look forward to starting our first case next Friday.
All right. Thank you. Bye, everybody.
Thanks, guys. Take care.
Mhm.